My name is Paola Bello. I'm the Director of Innovation at the Center for Primary Care. And we're very excited this year to be partnering with MIT Boot Camps to host our first healthcare entrepreneurship boot camp that's happening this August. And as a reminder, if you're interested in applying and you haven't done so already, tonight is the deadline for our early bird discount. So make sure you get your applications in by midnight Eastern Standard Time. And to do so, go to the website bootcamp.mit.edu. I'm also really happy to announce that we're going to be offering CME 27.5 contact hours for CMEs for the boot camp. So if you are a physician, nurse, healthcare professional, there's an opportunity for you to also gain some CMEs by attending the boot camp, and you can find more information on our website about that as well. So I'll get us started here. I'm very happy to have Andrew Schutzbank here from Iora Health. And he is a primary care doctor as well as the VP of product development at Iora. And Iora promotes team-based care that puts the patient first and offers technology built around people. And today we're going to be talking a little bit about some of the challenges that Andrew has come across in healthcare and in his years in practice and at Iora. And I'm going to kick it off by handing it over to Andrew and asking him to give us a little bit more details about his background, some highlights, and also what led you, Andrew, to have such an interest in healthcare innovation and working with Iora.
Thank you very much, Paula. Andrew Schutzbank here from Iora Health. I'm excited to be here and not see all of you and not hear you laugh at my jokes, which will be a challenge for all of us. For those of you who've never given a webinar before, the total lack of feedback is it's almost like being on TV, but not quite. So I'll do my best here for you. So I've been with Iora for 7 years now, since we've gotten founded. For those of you who've been through medical education, you'll realize I'm reaching the tipping point where I've been out of med school and residency for almost as long as I was in med school and residency. So I see this as a significant year of legitimacy and career development, and so excited to be at this point. So my story in primary care innovation actually starts in college. When I was a senior in college, one of my dearest friends already knew that I was going to medical school and told me that I was going to be a primary care doctor, and I was insulted. And I said, why would I want to be the lowest paid, least rewarded, most looked down upon, never-ending treadmill type doctor? That makes no sense to me. I have much more ambition than that. I want to do greater things. He said, no, you're going to be a primary care doctor. And so, so Ben is usually right, and Ben was right. And so come medical school, I resisted the urge and the call of internal medicine and tried almost every other specialty and found the same problem over and over again, which is I was far more interested in the people that had the problems than the problems themselves. And so this is the essence of primary care, is you help people solve their own problems. And the problems are, the variety of problems is what makes them interesting, as opposed to those who specialize, where it's the specificity and the depth of the problem that makes them interesting. And so that's really, the corollary is generalism can be treated but not cured. And so I'm a generalist, and it's a disease I'm afflicted with and have been forever. So here I was, wanting to change the world for the better, because that's what we all do. I'm the eldest of the millennial generation, and so we're cursed with the promise of changing the world. And so wanted to change the world, wanted to be a primary care doctor, and how can I do that? And so looking at the health system more broadly, it made a lot of sense that primary care was a super important aspect of this healthcare system that was being totally mistreated, underfunded, misled, mispaid, everything. And so it was actually, the whole world was wrong, not what I wanted to do with my life, which should have given me pause, but didn't. And so I said, all right, well then how do we go ahead fixing primary care? And pretty quickly there were like four options available. There's the academic route, the government route, the large private practice route, and then the technology route. Those are the ways that people are changing the world at the time. And so I decided I really love taking care of patients, wanted to do that. Love building a technology, but not for its own sake, really for the speed and seamless service that technology could help us provide. And so that's where I ended up. And so met Rashika when I was an intern in residency. He's telling me he wanted to start this company, and I basically didn't let go. So for life advice for you out there, get up early and be willing to travel are probably the two most seminal pieces of advice I can give you. And then also, if somebody gives you a chapter to read the whole book is the other one. Those are some of the experiences early on that got me here. Just communicating to those around you that you're worth teaching is probably one of the most important things that you can do, and you'll find that doors just open if you are responsible and dedicated and diligent and enthusiastic. And so that's a big part of my story. Along the way, it's just worth noting, was at Tulane for medical school and went through Hurricane Katrina. And so that was its own set of experiences, which really led me to believe in the power of opportunity and agility and focusing on one thing until you get it right, and dealing with major disaster and how to pick it apart piece by piece. That was a formative experience that I talk about periodically, but it really helped me understand that the opportunities to make the world better were much bigger than I was seeing in front of me as a medical student, as a resident, in the kind of confined space that I was in. And that's true for all of us, that the world we're in is not the whole world. And it's always worth looking what's out there to see what else is going on.
You mentioned Roshika Fernandopoul, who's the founder of Iora. Could you actually, before I go with that question, I forgot to mention to the audience, if you have questions for Andrew, please feel free to type them on the right-hand side in your chat box, and I'll be moderating the questions throughout the webinar. So we want to make this interactive as possible. So getting back to my question, so you mentioned Roshika, who's the founder of Iora. What would you say was the main problem he was trying to solve when he started Iora, and how close are you to having solved that problem?
So, the mission of the company is to restore humanity to healthcare, which is a really specific choice of words. The underlying thinking goes something like this. Healthcare is extremely important. It's something we're all going to experience multiple times throughout our life, and we all want it to go well. We know it's a huge part of the industry, of our economy. It's a huge part of our country. It's a huge part of our lives. We also know that there's almost any configuration of healthcare could be better than what we have today. Right? There's almost no, like we could, as the chairman of Iora, Chris McCown, says, if healthcare innovation were illegal, there would be more of it, right? And so that was more true in 2011 than it is now, but we were just not doing the things that we needed to do to take care of each other. And so the concept of humanity and restoring humanity is this. People have been healing people since there have been people. It is the relationship, it's the truth, it's the trying things to see if they work, it's the lack of judgment when they don't, it's the continuing to maintain belief and hold faith with your patients that they will improve in some way. It's knowing them enough to talk them out of their craziest ideas, etc. That's what ultimately gets people better. And what we've unfortunately reduced ourselves to in healthcare is a series of transactions. And so the entire system, if you really think about how we pay and how we interact, it's a bunch of transactions. And that works in a lot of other industries because the transactions are really clear. If I go to buy a sandwich and you give me a sandwich, I am happy, you are happy, we're done. If you're a fan of Clay Christensen, they talk to this as the value-added business. The problem with healthcare is, especially in primary care, no one knows what's going on when you're starting. So somebody will come in, so patients come in one of three ways. They need something specific, they need something general, or they have a problem they want to talk to you about. Right, so I need an MRI for my back. That's the specific one in general. The specific one is I need you to fill out this paperwork for me, and in general, it's my back hurts. Right, that's most of all scenarios of why a patient would initiate care for one reason or another. So they're usually very certain as to what's going on, and as a physician, as a provider, you start hearing what's going on and formulating all these ideas. And if you're not careful, you'll start doing stuff before you get a chance to listen. And patients will then judge how well you performed on the transaction they intended, rather than what was the problem you're trying to solve in the first place and did you make any progress? And so that's where the idea of humanity comes in, because that's an expression of humanity and of relationship. And it turns out it's really hard to get there. And so the Iora journey started probably 20 years ago at this point, with Roshika starting a series of organizations, really tackling each of the parts of the healthcare that were driving transactions over relationship. And what he found to be true was you couldn't just change the payment model and not change the team and the technology. You couldn't just change the team without changing the technology and the payment model. And you couldn't just change the technology without changing the team and the payment model. You had to change all three at once. And so, and he knows this because he tried every other option. And ultimately is what we came to. And so Iora was actually born out of his last venture, which, if those of you are familiar with the 2011 Atul Gawande piece, The Hotspotters, where they talk about Roshika's work and also Jeff Brenner's similar work in New Jersey. Before Iora, Roshika had pretty good control over the team and pretty good control over the payment and no control over the technology, and Iora was sort of the last piece, and that's where it came from. And I met Roshika just as he was going through this transition of, and one of the early questions of Iora was, Should we start a consulting business and help other practices and other systems get better? Or should we just build practices ourselves? Personally, I was always a fan of building our own practices because I wanted to do it right. But interestingly enough, the market was screaming at us to build our own practices. So as we were talking to seasoned leaders in all walks of healthcare, whether they're health services, large provider groups and hospitals and insurers, they all, the better ones resisted the temptation to try and make themselves better and kind of gave us a green light to just try it ourselves. And that was a really important moment because Iora wouldn't be what it is today if we weren't building it all from the ground up.
Excellent. And so let's dive a little into the, the current challenges that you're facing. So in the context of healthcare, what would you say is what keeps you up at night right now in terms of having to solve, one of the bigger problems that Iora or healthcare in general might be facing?
Sure. So healthcare in general and Iora are a little bit different. Iora has a million little problems. Any of you who've worked in any organization can think of all the things that are going wrong that didn't go the way they did. For those of you who don't have as much work experience but have gotten married, it's basically the same idea, which is you've planned a wedding in your mind, but the actual wedding that happened was disappointing to you but great for everybody else. And that's exactly what running a business feels like. So we have all these high hopes and beliefs and dreams of what's going to happen. What actually happens ends up being really good, but we only see the parts that didn't work. And so there's this combination of being despondent and ecstatic at the same time, which is the experience of running a business, running a startup. And so for us, so I'll start with healthcare in general. I think the fundamental problem in healthcare right now is that we're stuck in very entrenched ways of doing things. They're very large, very powerful players who will take too long to change or disappear. And those are kind of the two options, right? They either disrupt themselves or somebody else disrupts them. And the challenge, the reason why I think this is true, it has a lot to do with the regulatory environment, the underlying risk of health behavior in general, and there's a certain irreducible scariness of taking care of patients. But fundamentally, the problem I think we have is we don't have a customer. So almost every other industry and every other innovation, the person you're trying to solve problems for is the one that usually pays you. And so you're able to build a product or service, get money for it, and then get feedback from people who are using it to see if it works or not. And the real challenge in healthcare is we have the third-party dual system where there's a lot of things we want to do for patients. And the reality is very few patients, almost none, are in a position to put in any more of their money or time, frankly, into the healthcare system. So they benefit from it, but they can't pay you for it. So then the next logical customer is to go to providers of care, physicians, et cetera. And I will tell you as a provider, we're busy and free isn't cheap enough. And so even offering free services to providers still distracts them and still messes up their workflow. They're operating on such thin margins, such precarious balance, that the addition of a new thing is usually just not worth it, right? The risks are so high. And so providers find themselves in this local minimum, right? Where they're stuck in a valley, they can't get on either side. Yes, the world is better in either direction, but they can't get there because the risk of change is too high. As you go to larger provider groups and hospitals, they're willing to try things, but you end up in this pilot to death phase, right? Or you just think in one hospital system, you can't do it in another. And so the sales cycles are incredibly long. Spoke to an individual who was formerly in the toy business, who's getting into healthcare, basically supporting his son's company. He said, the problem with you healthcare people is there's no Christmas. He said, store owners can negotiate all they want and push back, but come September, they got to order the toys because Christmas is coming. He said, healthcare, you people talk for 2 years and not do a thing. And unfortunately, that's true. Again, regulatory environment, complicated technology, complicated problems, but it's still true. And so often sales cycles can exceed funding runways, which is a problem for new companies. And then the last is you have healthcare payers, health plans. They actually will fund, they actually do tremendous work in funding a lot of this work, in paying for it and being a customer healthcare innovation. But they have an engagement challenge with patients as well. So they're always one step removed from their patients. And so they'll pay for your product, but then you can't get anybody to use it. And so you have sales without feedback. And so you don't know how to make your product better. So I actually think fundamentally the problem in healthcare is there's not a clear customer, which means innovation is slow and all the other benefits we get in every other industry, which we want to apply to what seems to be one of the hardest problems out there. It's hard to access them.
So that's a really good point about not having a clear customer. But what would you say as an entrepreneur? Who do you focus on first, and as you're designing a product or a service, who would you recommend focusing in on first?
Patients. So everybody ultimately cares about patients one way or another, whether it's their well-being, their engagement, their premium dollar, the amount of money they're spending in the healthcare system. And the nice part is patients is a broad term. What we found at Iora is that one of the disadvantages that primary care has is we have the inability to anticipate our demand. So like an emergency room, you don't know who's coming in, you don't know when they're coming in. Unlike an emergency room, we actually have a broader set of things people come in for. I want a checkup, my wife is cheating on me, I need medicine for this, I need whatever, it's random what's coming through the door. And what the Medicare Advantage specialties have is they can focus their offerings. So if I deal in heart disease or a subset of heart disease, I can really tailor my whole operation around solving a few problems incredibly well. So what we've done in primary care, what I advise to everyone is finding a subset of patients. And it's patients, people don't organize themselves by their disease category, just to take that one off the table. So looking for diabetics and building businesses for them, not a good idea, because that's not how people identify. As one of my colleagues, Duncan Reese, likes to say, being sick is a club nobody wants to be in. So you got to find another way to segment your patient population. In the past, we found working with employer groups and self-insured unions works really well because they tend to concentrate. And then now we work with senior population, who's still wildly diverse, but less diverse than the entire population. And so for us, that ability to focus on patients, focus on a niche or subset of patients, and really start to get enough volume to justify excellence really helps you organize whatever your service or product offering is, almost more than anything else. And the truth is, if you can convince individuals to pay you, you're in good shape. But if you can prove that patients want to use what you have, you're already way ahead in the fight for someone else to pay you to give access to them.
Great, that's great advice. So we have a question from the audience. Kendall says, I'm an internal med intern. I have ideas, but have struggled here in West Virginia trying to locate anyone interested in med tech. What are your suggestions to best connect with other people who are trying to solve problems?
Sure. So first of all, keep going is the first one. I nearly quit intern year. Rashika saved me. And so everyone wants to quit intern year. It's okay. Keep going. Keep the energy going. The other way I describe myself as an intern was as a tire stuck in the snow, all power, no traction. The truth is, as an intern, all you want to do right now is meet people that you can. It's very hard to get anything done because you can't predictably be available to people when you need to be. So the first thing, most important thing is keep going. The second thing is lower your expectations. Because if you don't do those two things, you're going to quit. So keep going. So the next thing I'll tell you is you already have a network, whether you know it or not. My network actually started in my residency. I went to my program director who was doing fellowship counseling. I showed up. She asked me what fellowship I wanted to do. I said I didn't want to do fellowship, but I heard free advice was being given out. And so I went. She actually sent me to our division chairman, Russ Phillips, who now runs the Center for Primary Care. Russ was more helpful. Russ connected me to 10 people. And then those 10 people turned into about 75 more. And every conversation went something like this. It opened with an email. I'll give you the magic email right now. Use this for the rest of your career. It works great. It'll work on me. Please don't send it to me. I'm kind of busy. Kidding. This is why you're great. Don't actually say this, but say something like this. This is why I'm great, or going to be great. Another way to put it is, this is why you're great. This is the problem I want to solve. The key question, do you have 30 minutes to tell me about your story? What do you do? How did you get there? That's it. And if you have a warm connection, if someone sent you, even better. Everyone wants to tell you their story. I'm doing it to you right now. I'm having a blast. And so inviting people to tell you their story for a fixed period of time with no other ask is very important. If you're asking for work or an internship or a project or a job or a collaboration, you're talking to very busy people who already have way too many opportunities they can't execute on. And so you're actually adding to a pile that's already full. But if you want to give someone a chance to shoot the breeze and tell you about themselves, you're going to get high hit rate. And then just start the chain, and all calls will end in 1-3. Either they won't happen or they will happen. They'll lead you to someone else if you're not a good fit. Where every now and again you'll hit on somebody that you'll stay with for the rest of your life in one way, shape, or form. Just keep having the conversations and keep talking to people. Phone works great for this because it's low commitment. In person, if you can do it. Get up early in the morning, stay up late with call and all that. But that's my advice. I was an advantage being in Boston, but there's stuff happening everywhere. Or you can use communication technology to get everywhere.
Yep. Thanks, Andrew. We have another one here from Asim. You mentioned large hospital systems having long sales cycles. How does a startup cut through the systematic red tape problem and dislodge incumbents?
I don't know. Seriously. So the two main strategies have been, actually the only main strategy that I'm aware of is an insider strategy. So you either get someone involved in your organization that's highly connected that can cut through some of the BS. They give credibility to your startup before everyone's even looked at your product. If you have a general insider, that's great. They're hard to get and very expensive. The other thing is you'll often have an insider or contact at one facility. So this is a good way to get started, but it's a risky strategy because that insider often won't work at another facility. And so if you could get in Hospital X and get a pilot going, you actually have to prove after a long period of time, usually that exceeds your funding, that your thing worked, then take those results to the next group. And what I'll tell you is clinical people are suspect of all results is what we're trained to be, right? New drugs kill people. Old drugs tend to not kill people. They've been around for a while, and bad new drugs don't become old drugs. So we're generally skeptical and we don't really believe your evidence ever. And so you have to be prepared for all that. So it's hard to get through that red tape. The best thing I've seen is an insider strategy or finding ways that you don't trigger it. But if you find that solution, that's its own company, sell that.
And what about Iora? Do you engage with startups? How do you, I'm sure you have people reaching out to you with ideas and technologies. So I'm curious how you guys manage that, being a startup yourself in a small team.
So this is one of the most fun and least fun parts of my job. So I'm one of the point people for looking at new technologies that can help us out. And unfortunately, so what I can tell you, if anyone's ever read anything by Robert Ringer, go for it. He's a very entertaining writer. The first rule that he tells you is most deals are unmakeable. And so if you go in with that attitude, you'll live a much happier life. So my role is to look at technologies all the time, technologies, startups, processes, partnerships that could help us. And what I can tell you is I probably talk to 1% of them, and then we'll do any kind of deal with 0.01%. And the truth is we're looking for something that already exists that we don't have to build with you because we're building our own thing, we don't have time, that we can pay for. So if we can't pay for it, that's usually a sign that it doesn't exist. That solves a problem we already have, not a problem we'd like to solve someday. Now, how you figure out what problems other companies have is up to you. And we think can reasonably either get work off our teams or fall into our workflow so nicely that we do it. And it also cannot involve your organization talking to our patients for us. We've got a lot of bad stories there. So with those criteria, that's why we do, I would say 0.01% of all leads, offers we get, do we ever move forward with. It's a hard game out there. And the truth is, a lot of people have great ideas. They're not honed enough, or they just solve a problem we don't have yet. Sometimes we're not mature enough to solve the problem. It'll be a problem for us in 3 years. The other thing I'll tell you is life is long, hopefully. And so stay on good terms. You'd be amazed how we reach out to people 2-3 years later because we're finally ready to avail ourselves of that solution. Sometimes it still exists, sometimes it doesn't. But just being in touch and setting a yearly frequency of, hey, how's everything going, is important because we'll eventually grow into the problems that you can imagine we'll need, as will other organizations.
Great. And then we have a follow-up question on the pilot death phase that you mentioned. How do you get out? Do you have any advice on how you get out of that phase, or how would you resolve that?
Yeah, talk to John Moore of Twine Health. So of all the people I've ever seen do this, John was the most successful at getting through pilot hell, pilot death, getting out and getting something that proved his organization, his product worked. So Twine Health is a very interesting story. It's a phenomenal product. I've actually gotten to know John since he was in graduate school. And so I finished residency around the time when he was finishing graduate school. So I would just defer you to someone much better at this than I am. We've avoided pilots. So Rashika fortunately knocked all those out of the way by the time that I got here, which was nice.
And I believe, weren't they just purchased by Fitbit or something like that?
Yes.
Twine Health? Yeah, they've done a good job. Another clarification question is, can you please speak more about your revenue model and the meaning of not transactional?
Sure. So let me start with what I mean by transactional. So there's the cash, there's the financial transaction, but then there's also the service transaction. So the cash transaction in healthcare is primarily fee for service. You go, I do something to you, I write down a 5-digit code and a bunch of words that proves I did it, or I stick a needle in you, et cetera, et cetera, et cetera, and someone else pays me on your behalf, maybe you pay me a little. And so everything we do is concrete and defined. And the truth is, that's not what work is actually like. And healthcare is certainly not like that. And certainly when your job is to listen to someone, to hear them cry, to help them make end-of-life decisions, starting to reduce that into a code you can get billed for on a one-to-one basis, it loses meaning very quickly. And it also blunts your thinking and creativity on how to help people. So what we do as our revenue model is we are a variety of value-based contracts. They've come in a few different flavors. Most of our work now is through Medicare Advantage, where we're taking risk on a population. And so we actually get a subset of the total healthcare dollar, which we then turn around and spend on their behalf, and then keep the difference. So it's kind of the risk-based contract. What you realize is there's only a few revenue models out there for healthcare that exist, and they're all flavors of one another. There's fee-for-service, which is I do a thing, you pay me for it. And what I'll tell you is if you can clarify what it is you do, when you need to do it, and if you did it right or not, fee-for-service is great for you. So it is right for certain parts of medicine, just not all. So the next one is basically some form of capitation, which is per head. So we get paid basically the capitated rate, which is per person. There's something called risk adjustment, which is the idea that you'll get paid more for sick people than healthy people. Medicare does this the best. The reason why they do it the best is they are uniform and consistent. So there are problems with the model, there's challenges, it changes every year, that's complicated, but everyone gets the same deal. And if you're taking risk, you want the same deal as everybody else, because you can imagine a world where your deal is more important than your care or your service or your product. And so you can win on the merits of the deal rather than on the product or service itself. It's a bad place to be. So then when you get into some kind of share of value, there's two main models. One is called shared savings conceptually, and the other is called risk share. So shared savings is basically this, and I generally advise against it in concept. You're currently spending X amount of dollars. I think I can get you to spend less than that. Let's split what we save. And here's the problem. So in the shared savings model, the revenue is the premium dollars, is real money. It's the number of patients times a premium. It's a real amount. The costs are fictional, because a certain population will accrue certain costs, but you have to compare them to some other population. And there's all sorts of case control methodologies and different ways of trying to figure out what should they actually have cost. To me, that's answering the question, how many angels fit on the head of a pin? And so if you're a small organization or a big organization, they're going to win one way or another. So even well-meaning people will disagree on what cost should have been, and time is not on your side. While you guys are figuring out what the cost share was, you're running out of money and they're not, right? And so you're on the wrong side of that asymmetry. Furthermore, cost share, saving sharing is boring, as our chairman likes to say, because it takes money to take care of people. So maybe there's 40% waste in the system now, and you start engineering it out, there's a limit. There's not infinite upside to saving share. Plus, as you get closer to the asymptote of what care costs, you'll get squeezed harder. And at the same time, your payer will think, well, maybe we can do this ourselves. So that's all the risks of shared savings. It may be easy to get started, and it seems appealing. I would advise against. I can tell you that those are mostly, that's a mix of actual experience and theoretical experience. So we don't have shared saving skeletons in our closet, but thinking through the logic of it, I would be a little wary. Risk share is the last one, where in the last version where the revenue was real and the costs were fictional, now the revenue is fictional. Certain number of people times a certain dollar factor, and we'll just pay you that amount of money, we'll take some for ourselves. And then the costs are real. There's real transactions and real care and real things that happen that you got to pay for, and you keep the difference. Providers have a lot more control over patient behavior in where they get their care, not so much how it costs, how much it costs. That's more the payer behavior. And so the risk share works a little bit better because everyone does what they're good at. The payer's job is to make sure that they're getting a good price for the services they offer. They do a lot of things to try and navigate volume of services, but they're more than happy to cede that to us over time, because payers have to use more blunt instruments to prevent volume, prior authorizations and network limitations, and their hands are a little tied in how they can direct volume, and it's appropriate because they don't have a one-to-one care relationship. On the provider side, we have a one-to-one care relationship. I know what you need, and so I can send you to where I think you should go, tailored for you. So that actually allows us to intervene earlier, to make sure things are working, to keep you away from specialists or facilities that you shouldn't be going to intervene in necessary testing, to make sure that your goals of care are represented. And so we're able to bring the volume of care down in the right way, not in the blunt way. Plus, as people get better, they use less care, right? And so there's kind of the double effect. So that's where risk shares work for us as a revenue model. That's what I mean by the purpose of all of that, though, is just to get one patient and one health coach and one doc to just think about what the patient needs and not worry about what we have to do for Iora, right? That's the mistake, is if your business worries about what your patients have to do so you make money, you're totally backwards. You need to worry about what you need to do for the patients so they stay your patient, and you got to figure out how to make money out of that.
So another question from Giovanni says, can you provide an example of a good deal that helped the company to grow and to increase its visibility in the healthcare market?
Yes, so all our Medicare Advantage deals. So Iora has been in Medicare Advantage since 2014. Our first partnership was with Humana. That's been a very important partnership for us. What it's allowed us to do, it raised us to a new level. Before that, we were working with self-insured employers and unions, which mostly have regional influence. Working with Humana, working with Medicare brings a level of national importance. Everyone's going to run into Medicare eventually. We got to it 4 years into our operation, and that was a good thing because we got a lot of things out of the way before we got hit with a large amount of regulation and constraint, which, while well-meaning, can be overwhelming to a new organization. And so my fear is too often, if you start too close to a regulated environment, you just have to conform to the environment. It's too hard to know what rules can be negotiated because it's overwhelming to you. And so we started in a freer space, and they were able to show up with a lot more experience when we got into a more regulated space. So I'd advise that as well. Wherever you can avoid starting in a tightly regulated space, because your options are limited. And as a new player, your ability to shake things up is limited because nobody wants to give you the benefit of the doubt, right? They don't trust you. You don't have a track record of doing it right enough to trust you to want to do it differently. So we entered Medicare in 2014 and 15 with Humana, and they've been able to grow in multiple markets, multiple regions. There's branding opportunities. It's brought a new class of investor on board. It's also allowed us to leverage that into other Medicare Advantage deals. So we have Medicare Advantage contracts with most of the major Medicare Advantage payers in the country as a result. And so we found a great home there, and then it allows us to do the same things across the country in a way that almost no other payer has worked with us.
Great. I'm going to paraphrase one of the questions here a little bit. They're wondering how you bootstrapped Iora in the beginning, and I think this leads to an interesting question about the funding mechanisms that Roshika was able to secure early on, which is, I think at the time, pretty unique for a primary care focused company to secure external funding. So if you could address that a little bit, and how you identify the right investors for your idea.
Yeah, so it's fascinating. So the story of Iora really kicked off when Roshika Fernandez-Pillay, our CEO, met Chris McCown, our chairman, which I think 4 or 5 different people take credit for the introduction, because why wouldn't you? So Roshika is fairly well known. I think he's at the share level of single name recognition in the healthcare industry, which is a pretty cool thing to be. Chris is not. So Chris actually founded and ran an organization called Health Dialogue, which he had sold prior to joining Iora for a very large sum of money. And so Roshika brought the vision, the passion, the experience through the Atlantic City work and the operational experience. What Chris brought was the tried and true entrepreneur. What I can also tell you is he has an overwhelming gravitas and wisdom and calming presence about him, which you just want to listen to Chris, right? He just is a excellent leader. And so the combination of the two allowed us to be a little more choosy on who we would fund. A lot of people who were involved in Chris's earlier work were more than happy to try and invest again. And so we got a leg up. Chris also has great experience in kind of leading and managing and guiding the rest of us through that process. And so Roshika knew what he was doing, but Chris had a lot of experience with it. And so that partnership was really important. The co-founder relationship is a very important one. And I think you'll see this a lot of successful organizations where there are multiple sets of complementary skills that have to be brought together. And so for us, it was really Roshika plus Chris that gave us access to the right funders. And what I think what Paolo was mentioning was a bit unique is we went for venture capital funding early on. So most of the traditional routes were foundation grants, government grants, loans, any other way of getting practice companies going. And we both found that we didn't have access to the ones that we wanted because most of what was being funded was not that different than what existed today. It was really kind of small iterations on what existed today. as opposed to what we were trying to do, which is a big change. And then also, we found that the nonprofit route didn't offer us the flexibility we wanted in terms of type of funding and the way we could get it. And so we've been very fortunate to have a fantastic board who has guided us very well. I mean, they obviously, Rashik is a leader in the field, and his expertise and input is weighed very heavily. The board has been helpful in pacing. I think if we're up to Rashik and I and a few others, we would have 9,000 practices in 50 countries yesterday. And so it's a lot of that wisdom of being strategic about where you go, when you grow, how you make it work. That's been a nice combination to our energy to change the world.
That's great. And Pamela asked a question that actually was on my mind as well. How do you think how will the potential Humana Walmart merger impact your company? And in general, all of these retailers getting into the provider space. Curious to hear your take on that.
Yeah, so I mean, this is pure speculation. I think it's fascinating to begin with, that these organizations are buying each other up. We've been, I'm trying to think of which metaphor is right. So we've been in this space for a while. Think of us as a small little tugboat getting a little bit bigger, There's some large barges coming through, right? So the industry is shaking up, it's changing. What we've found is, the first and foremost, these big deals are very distracting to the industry. So a lot of focus gets put on them, whether you're an involved party or not. And so other things tend to slow down while these big things are moving through. For those of you who remember the Humana Aetna deal, Humana and Aetna spent a lot of time focusing on each other during that period of time, which is appropriate as a massive merger opportunity. And so in general, the deals themselves tend to slow things down. And then when they're complete, my expectation is things will speed up like crazy. Because you have a bunch of organizations that have all this information and service lines that used to be, they would only talk to each other if they had to. They talk to each other to get paid. And they didn't always have good business reasons to share information together, and now they're going to be the same entity. And so all the information that's been separate from one another, payer data and pharmacy data and clinical data, that everyone on the data and technology and academic side has been waiting to be pulled together, will start to be pulled together. So there'll be a tremendous amount of work to figure out how to use that information, how to put it together, match it up. It's complex stuff. So I think there'll be a big tech and data play in the wake of all of these mergers, and some will be internal, some will be external, but people need to figure out, what do we do with all this information? How do we put it to work? I also think you'll see a lot of more service experimentation in pilots and test markets. So the likelihood that two giants like Walmart and Humana are going to come up with a big service and roll it out quickly seems unlikely. It seems much more likely you're going to see things cropping up in different markets they're going to be trying. So I think you're going to see a lot more experimentation. I think, frankly, it's an interesting time. And it's also, the question I think everyone should ask for themselves is, what is everyone getting out of the merger, to see if it makes sense or not for the organizations and larger.
Great. And this next question, I think you'll probably spend an entire webinar on this alone, but if you could, maybe share some thoughts around pricing for healthcare, right? So as you're developing a product service, how do you even go about thinking about how you might price that?
So this is a challenging one. So it starts with who the customer is. That'll tell you a lot about pricing. If your pricing is for patients, it has to be relatively inexpensive. There's just no way around it. If your pricing is for providers of care who are in any kind of risk or value-based arrangement, you almost always end up as either a transactional pricing model, you'll pay me every time you use this thing, which you don't want because then no one will want to use your thing, or a per person per month fee, right? So you get, I'll make up a number, $50 PMPM, or the CPC Plus program in Medicare is $13 PMPM. What I can tell you is, if you're going to be a value-added service to an at-risk provider group or at-risk payer, you want to get your price down to like less than $1 per person per month. So people come at us and say they want, $12 per person. It's a staggering amount of money in a proportion to what we make and we get paid. And so that means you need to be offering a fifth or sixth or 10th of what we're the value that we're creating for our patients. So starting with your customers, you can start to figure out the pricing models. If you want people to use your product, I would avoid all per use fees. You want to make it as buffet as possible if your business can afford that. If you can, if it really costs you money every time someone uses it, then you want it to be on a per service basis. But in general, getting your product or service in use and getting paid for it is the most important thing, because the only way you can get the feedback you need to build the right product or service.
Great. And then how about quantifying your value proposition in healthcare? You're in a tricky situation where to provide that information, you have to start providing your product to patients most likely, right? But then how do you go about that if you're trying to approach a payer for, to sell your product, so on and so forth?
Yeah, so this goes down to the, so a second corollary to most deals are unmakeable. The second one I stole from Silicon Valley, probably stole from somewhere else. Being early is the same as being wrong. So a lot of the ideas that you are likely on this group are things that are gonna be, you're right. You are seeing the future. The world's gonna move in that direction, but they're not there yet. And one of the ways you know that is if you have to do too much proving of your concept. So if you have to prove a big concept and you can't prove it without the opportunity to execute your concept, you're too early, unfortunately. And so either sit on it, keep fighting it, try and find a way to prove it otherwise. But in general, it means there's not enough of an upswell or enough faith in the industry that particular solution works for someone to fund you or buy you on a whim, right? And so in some ways, if you have to prove your product works before you can use your product, you're probably too early, or you're misunderstanding the problems of the people you're trying to solve. And you're probably trying to solve a more of a complex or advanced problem because you couldn't possibly believe that they have actually really simple problems. And so I'd encourage you to come up with a simpler problem to solve than the one you're solving.
That's a great answer, Andrew. So getting back to maybe some of the potential opportunities to resolve, what would you say that is the most surprising thing for you that has not been solved yet in healthcare?
Lists of names. I talk about this a lot. Paul hears about this all the time. Knowing who someone is as a patient or a provider, their current contact information, if they're a patient, are they my patient or not? Are they alive or dead? If they're a provider, what addresses do they practice at? Are they in network or not? What is their, these problems, these contact detail information are massive problems for everyone. The underlying issue we have is if you want to operate within a network, it's good to know who's in the network. And if you want to take risk on a population of patients, it's good to know who the patients are. And what I can tell you is those processes are much more lagged than you would believe. Lists of names are still hard things. This is usually where blockchain enters the conversation. That's going to fix everything. If they could just get on with it already, that would be great. But you'd be surprised at how hard of a problem this is. I think one of the most important companies to look at is Cover My Meds. So it's about a year-old, 2-year-old story now, but they helped providers and payers navigate the payer prior authorization process. So if you think about this, if those of you ever watched or read Fight Club, prior authorization is a fake problem, right? We invented it as a healthcare system to try and solve another problem, which is overuse of care. So like we could imagine a world where prior auth no longer exists. We probably couldn't imagine a world where medicines no longer exist, but prior auth could go away. So Cover My Meds did was solve, but it's basically a fake invented problem, of which there are many in healthcare, and they exited for $1 billion. So just read about them, learn about them. I think it's a fascinating company story of how you pick a very simple problem that most people would overlook. But those are the types of problems that are challenging. Just navigating and organizing. Another problem that we have along the lines of no network is, since we do distributed primary care, most of the ways we interact with the outside system is through fax. So there's direct messaging protocol, that's kind of cool. But we built a way that we can order labs from pretty much wherever we want. That's cool. E-prescribing was sort of figured out a long time ago. It still has some problems with it, but it works. Radiology doesn't have a similar solution. So those of you who are in healthcare, if you work within the system, it's easy to order x-rays from your own system. Try to order an x-ray from a competitor system. It's impossible, right? And so that's us. We're the competitor, we're with a lot of systems. And so a lot of the information communication ordering networks don't exist. So we either have to build them or hack them together in a pretty frustrating way, because you can imagine that manual processes are more prone to error, which means you have to spend even more effort to make sure they work, which adds more manual steps, and so it's a bad cycle. And so the lack of interconnectivity, forgetting even complex patient data. Just, I want Mr. Smith to get an x-ray for this reason on this day is hard enough to move today.
And has Iora, one question we have here about, I guess, the lack of interoperability of data, how have you as a care team dealt with that, or how are you trying to deal with that?
Variety of ways. So we're always looking at what technology protocols are out there, whether it's the CDA protocols, the CCD protocols, the FHIR protocol. We are involved with some of the state information exchanges. I would say that Iora is a fast follower when it comes to data interoperability, just based on our size and scope, what we're able to do. And we end up just spending a lot of diligent, manual, hardworking care team effort to make sure that things get done the way they need to. We've looked at using AI to sort faxes for us. I mean, anything we can. We're always looking, because the fundamental work is important, but no one in their right mind believes that we're doing it right, and that it couldn't be easier and more effective and faster and safer. And it's a universal in healthcare, unfortunately. And
you mentioned AI, and that seems to be the buzzword in 2018. So curious to hear, do you think it's a fad? Do you think it's going to really solve some problems? Would love to get your take on AI and how entrepreneurs might be able to leverage ideas in AI.
Yeah, so in my cynical way, all technology follows the same track, which is promising prototype, wild imagination of what it can solve, very specific use cases that it actually can solve. Some successful companies come out of there, and then we march towards the future. But then usually some new technology comes along that blows it out of the water. So when people think AI in healthcare, the first thing I always hear is decision support. People want to help have computers do the doctor's job. We're good. Thank you. Maybe we'll be replaced by software one day, but it turns out there's a lot of jobs in healthcare that are repetitive, that require some judgment but not a ton, that are much easier to describe, that are currently done by people who are looking at two screens at once. And I think that there's an organization called Crosschecks, which is fascinating. Their idea is you're never going to get the networks to talk to each other. Just instead of putting a person in between, put AI in between to do the human's job for them, the manual rote job. For any of you who ever filled out a healthcare form, you know what I'm talking about. And so where I think AI ought to come in is there are things in healthcare that require a human, but not a ton of a human. And so this is where, like, matching two names, right, or matching two people, a person can do it pretty well. It's kind of hard for a machine. This is where I think we're most likely to see the applications of AI on more of the administrative tasks where the work never ends. There will be no hard and fast rules we can ever put down. We're going to need human judgment, but not a ton of it. The human judgment involved is kind of like general human judgment, not highly specific, highly educated human judgment. I think that's where you're going to see AI win. And everybody who tries to build more doctor replacements and nurse replacements, it's cute, it's funny. I actually think the problem you have is not in the quality of the product itself. It's that the problem with AI complex services, the same thing with self-driving cars. Who do you blame when things go wrong? Because humans like to have other people to blame when things go wrong. It's the basis of our legal system. And so if there's no one to blame, people are not going to trust your product. And then the challenge I see is product makers respond by trying to make a better product. They're missing the point. And so I think there's a regulatory issue. It's a cultural issue. So if you want to work in AI, my suggestion is take complex, but not overly complex, administrative problems that organizations are forced to do that they don't want to do. And we would happily cede that to a computer that can make it go away and work right.
Absolutely. And a bit of a leading question. So I find that behavioral health, especially in primary care, is a big pain point, excuse the pun. So how do you integrate it? How do you provide better access? Curious if you've seen any technologies or startups that are doing this right. So I think this area is also still prime for entrepreneurs to innovate around.
So there's a ton of things in this space. I tend to see more great products than companies because I think it's hard. They have trouble finding customers. You can imagine there are organizations that do gamifying decision support, gamifying habits. There are coaching platforms that you require humans at either end, but they have a good platform. And that's more of the Twine Health play, at least last I saw them. The first one is more like Perk Health, which helps with nudging you in the right direction. You see some more sophisticated who are working on actual mental health diagnoses. There's telepsych, which I think is actually a great care because psychiatry based on the way psychiatry has evolved in the country, we don't have enough of it, and we have a large need for it. And so there are companies that do interesting work in telepsych. I think that's a gamut of kind of outside opportunities there. Again, I tend to see better products than I do companies because they're having trouble getting a lot of traction, but they're on the right track. Internally, we have integrated behavioral health into Iora. We've got a few iterations ourselves. The idea being the mind and the body were artificially split by Rene Descartes hundreds of years ago. And so we decided to pull them back together because they're tied together more than you can believe. And so that's still an ongoing work in progress for us, but it's core to our model that, we take care of the whole person.
That's great. And what would you say, we touched upon a little bit on this before, but for entrepreneurs who do not have a healthcare background, it's difficult to access, connections to physicians to sit down and talk to them. As you said, they're very busy. But what would be your advice in terms of, they have an idea, they maybe have a technology background or another background that's helpful, but how do you gain that healthcare experience? How would you recommend they learn more?
Yeah, talk to your customers. So pick who you want your customer to be and talk to them. So if you want to help patients, talk to patients, don't talk to doctors. Talk to them later. A mistake that's made in healthcare is over-reliance specifically on physicians for all things. It's because we have a license to make decisions. People use this as a proxy for patients, a proxy for other specialties, a proxy for nursing. There's a lot of disciplines in healthcare. Physicians tend to be overrepresenting their opinions, and we tend to be over certain of our own opinion, which doesn't help you because we can lead you down a dark path as a new entrepreneur. So talk to whoever you want your customer to be is the first piece of advice. The second is read and learn. I'll just sort of give you the hint now. The way medical care works, which is a subsection of all of healthcare, it's the opposite of the way it appears, which is most people think that there are symptoms, then there are answers, or diagnoses, and there's treatment. The truth is something's going wrong. You have to figure out what's going on in parallel and try stuff to figure out what the answer is and see if you got it better or not. In that way, medical care is actually more like agile product development than it is like manufacturing or other services. So I would actually, for those of you with tech backgrounds, go back to your Kanban or your Scrum roots and read about product ownership. I think that's the most easy to access parallel to being a physician that I've ever seen is being a product owner. And so understanding that and that discipline, finding value for a customer, values in the eye, and then healthcare then just becomes a set of vocabulary and superstition and guild culture on top of that, which you're going to have trouble breaking into. But again, speaking with customers works better than speaking with providers unless they're your customer. Great.
And then as we're nearing our time to end, do you have any sort of closing thoughts or advice for our future healthcare entrepreneurs on the call today?
Yes. So 1, keep going. Number 2, lower your expectations. So we covered those already. Know why you're in this game. Healthcare is one of the hardest industries to be in for a reason. Most people who are new to healthcare come in usually get a sickening feeling in their stomach. That's appropriate. It makes no sense. And everything is backwards. Entrepreneurship, at least the character or cartoon of modern entrepreneurship, has a lot to do with disruption and turning the system on its head and breaking things. Healthcare, if you're going to enter healthcare, you ought to have a high respect for the people that work in it every day. Healthcare is filled with some of the brightest, most well-intentioned people, and they are collectively ineffective at what they want to do. And so you can imagine the psychology of coming in and fixing it for them. If you think you're going to fix the problems of healthcare as an outsider, that's why you're being boxed out. Just to let you know that now. Come with empathy, come with humility, come with a real commitment to what problem you want to solve and an openness to all possible solutions. Don't denigrate those in the field now. Don't denigrate players. Don't make up enemies. That's an easy way to get you kicked out and no one has to talk to you. And someone once said to me, and we have patients to see, so we're going to go do that now. Right. So there's a big industry. It's a big guild. Learn the ways before you tread too boldly. That's my advice.
I think that's great advice. Thanks, Andrew, so much for participating today. And thank you to the attendees. Asked some great questions. I think we got a lot out of the call today. And so as a reminder, if you want to get in to the bootcamp and take advantage of our discount pricing, go to bootcamp.mit.edu before midnight tonight. And we hope to see some of you at the boot camp this August. Andrew, thanks again, and we'll see you soon. Bye, everyone.
Bye.